Good morning, everyone. If you'll go ahead and take your seats, we'll get started this morning. I want to welcome everybody to the ICD-9-CM Coordination and Maintenance Committee meeting. We would like to start by devoting the meeting today to the loss of a dear member of our IPPS team, Dr. John Cooper. And some of you, I guess, have not heard. He was tragically killed in an auto accident recently. And so it is a great loss for us. He was a wonderful person. He was a public health service officer, an anesthesiologist, and very helpful on all our coding and DRG things that we did. So we think about him this morning as we proceed on with the meeting. My name is Pat Brooks. I'm one of the co-chairs of the committee. Dawn Pickett, who's here, will be introducing herself later. She's representing CDC on the other half of the diagnosis part of the meeting. The ICD-9-CM Coordination and Maintenance Committee is a public forum to discuss updates to ICD-9-CM and ICD-10 codes. We do co-chair the meeting with CMS leading the part that has to do with procedure codes, and CDC leading the part that has to do with diagnosis codes. We are doing only proposals today. People have asked us to discuss updates, and we're proposing things. We're not making any final decisions. We welcome those of you who are in the audience here today to make comments, ask questions, give suggestions, but we won't make any final decisions today. As I said, no final decisions are made. We have hundreds of people who are listening by live stream, others on the conference line, and we encourage all those listening to send your comments in to us. The two topics we have that are ICD-10-PCS this morning, we've had a request that those be implemented on October 1st, 2014. You'll see CMS's recommendation concerning those two. But let me announce, and I'm thrilled about this, that the final update to ICD-9-CM code updates will take place on October 1st, 2013. So all the work that we've done on ICD-9-CM over the years since 1979, the final update happens in a couple weeks. We're not discussing any code updates for ICD-9 now or in the future. That's done. All work now is focused toward ICD-10. Currently, as you all know, we are in a partial code freeze. ICD-10-CM and PCS will be implemented for services provided on or after October 1st, 2014. So during this partial code freeze, we will only consider ICD-10 codes for new technologies and new diagnoses. Any other requests for code updates we're happy to consider, but those would be for an update on October 1st, 2015. So today, when you hear the requesters asking for code update, one issue will be whether or not a new code is needed. Another issue will be whether it meets the criteria for the partial code freeze, and if it does not, then the issue would have to be deferred for implementation on October 1st, 2015. And you're all invited to make comments on those issues. This is the last time we're going to call the committee the ICD-9 Coordination and Maintenance Committee. As we said, we're through discussing code updates. We're going to have our last ICD-9 codes implemented October 1st, 2014. So next year, when you come into the, March 2014 meeting, we're going to be renamed to the ICD-10 Coordination and Maintenance Committee, and so that hopefully avoid any confusion. We have a detailed timeline that we're not going to go over that's in your handout today. I would encourage all of you to read through that because there's a lot of very good information. There's links to websites that are useful. There's deadlines. I'm going to go over just a few of those timelines issues that are important. One of the most important issues is that anything you hear discussed at the next 2 days of the meetings about a code update, you have to have your written comments to us by November 15th, 2013. Donna and I both encourage you to send emails with those comments because if you send them through the mail, going through our mailroom and security, Sometimes we don't get those in a timely fashion, so we really love to get electronic versions of your comments. And the April 2014 proposed rules, if any ICD-9 or ICD-10-CM or PCS code were approved as a result of this meeting, you would read about that in the proposed rule in April. We would also mention that June 2013 is the last time we had the ICD-9-CM Addendum, and I've given you on this slide a couple of websites where you can go look at places where we post Addendum on the CDC website and on CMS's website. There was no ICD-9-CM diagnosis addendum this year for October 1st, 2013. However, CDC did post an updated conversion table that some of you will find very useful, and the website is given here. In June 2013, we posted a number of file updates. We posted the 2014 ICD-10-CM updates, and shortly after that, the GEMs, the General Equivalent Mappings. We also posted the 2014 ICD-10-PCS updates and the GEMs. We got the GEMs done a little earlier than anticipated. We thought it would be in October of this year, but because of the partial code freeze, there wasn't the huge number of codes, so our contractor 3M was able to produce those very quickly. We are still working on the reimbursement mappings, and those will be posted later. For the 2015 ICD-10 updates, you should look for those updates to be posted in June 2014. We'll also mention, if some of you are here to learn about the meeting and you're thinking about requesting a topic for a future meeting, you need to send any requests for topics to CMS for procedures, CDC for diagnosis, by January 17th, 2014. That is for the March 19th through 20th, 2014 Coordination and Maintenance Committee meeting. Some other information is that around August 1st of 2014, our final IPPS rule will be published, and at this time when we update the IPPS system, it'll be based all on ICD-10 codes. So there'll be links to the current codes involved. There'll be rulemaking about how those ICD-10 codes are included in the MSDRGs. And you'll see those updates are posted in June 2014. This meeting, we're pleased, like we did last time, to offer 3 ways to participate in the meeting. Some of you were able to come to the meeting and will be able to ask questions and comments from the meeting. Others are listening through the free conference lines we provided, and others are participating through a live stream of this. You should all have found the documents, the handouts for the CMS part of the meeting. They're on our Coordination and Maintenance Committee website, and hopefully you've all downloaded those or loaded them onto your computers or iPads. For CDC, they have posted their handouts, 66 pages, Donna, is that a new record, on the CDC website. And we hope by making this available to the public through these 3 different ways, we get more people involved in what's going on and get more comments later. No matter how you participate, though, live stream, in the audience, by conference call, we do want your written comments later. Sometimes you say something at the meeting and you think about it and you change your mind, and that is fine with us. That happens to all of us. You can send your later comments saying, well, at the meeting I disagreed with this, but now after second thought I agree. So we encourage those comments. We're going to provide a variety of updates during this meeting, the CMS part. We're going to give some updates on ICD-10 and implementation issues. We're going to describe the recently posted 2014 General Equivalent Mappings, the GEMs, and we're real pleased to make an announcement of the availability of the ICD-10 MSDRG version 31 mainframe and PCS software. We're going to be discussing that this morning. And then at the conclusion of this meeting, CDC will take over this part of the meeting, and Donna anticipates running through today and then picking up again tomorrow with all her diagnosis issues, because she has significantly more diagnosis issues than we do procedure issues. A couple of other announcements that I'd like to make. One is, and we have Dr. Dan Duvall in the audience here. Those of you who have represent physician office and want a nice explanation of what ICD-10 is all about and implementation issues, I encourage you to click on this CMS YouTube channel and watch the presentation. I did a small part of it, but I think you'll like Dan's part much more, because he gives hints on transitions to ICD-10 in physician offices. So if you want to, click on that and review that YouTube to get more information about implementation planning. If you want to receive notices about future videos that are posted or the ICD-10 calls that happen, on the same slide, you'll see that you can click on the subscribe link and you'll get notices when new information's out that may be of interest to you. Also, we have Sue Bowman here today. Sue Bowman was gracious enough to help us with our August 22nd, 2013 National ICD-10 teleconference. She did a teleconference on ICD-10-CM basics, which was just outstanding. We had over 27,000 people who listened to this call. It was a record, and we are continuing to have people to listen to it because after that call, we posted the audio files, and we posted a written transcripts and the slides. So if you're looking for an excellent way to educate your staff about what ICD-10 is all about and you want to do it for free, then I encourage you to listen to that call on ICD-10-CM Basics. She really simplified a lot of issues for everyone very nicely. And Sue, we really do appreciate your help on that. Any questions about the points we've raised so far? Okay, then I'm going to ask Maddie Hugh to come up and introduce our first speakers on the insertion of bone graft substitute.
Thank you, Pat. We're on slide, well, we don't have page numbers for the slides, but in your packet, we're on page 14, insertion of bone graft substitute. The issue is currently there is not an ICD-10-PCS procedure code to describe the insertion of a specific bone graft substitute known as P15 in cervical fusion. Should a new code be created? At this time, I'd like to introduce Jeff Marks, COO, for some opening remarks, and Dr. Michael Jansen from the Center for Spinal Disorders to present.
Good morning. I'd like to thank the committee for giving us the opportunity to present here this morning. So I'm Jeff Marks. I'm President and COO of Therapeutics, and we'd like to talk about a new technology with a very different mechanism of action for bone healing as compared to the technologies that are currently available, and why we believe that this should have its own ICD-10 code for its tracking going in the future. So we're going to go relatively quickly. I'm going to do an introduction. I'm going to talk about the technology, and then Dr. Jansen is going to talk about our FDA IDE Clinical Study. And then we're going to talk about the rationale or why we believe this should justify its own tracking code. So Therapeutics is a medical device company, and we have developed a novel bone graft substitute based on a peptide called P15, and we're calling it P15 Enhanced Bone Graft Substitute. So when we talk about our request for the code, we're not asking one specific for the product, but rather a category of peptides and the mechanism of action associated with those. So this material has a unique mechanism of action for the enhancement of bone repair, and specifically we're studying it in the United States for cervical spinal fusion. So there's a couple of interesting advantages as a result of the technology and the way in which it works biologically. First has to do with the safety profile. So this specific peptide has been approved by the FDA and in use in the dental field since 1999. As compared to some of the other technologies some of you may be familiar with used in bone enhancement, there's no ectopic bone formation with this material. There's no antibody formation, so there's a dramatically enhanced safety profile versus some of the comparative materials. There's no tumorigenicity. It's not derived from human tissue, so the potential risks of disease transmission associated with human tissue are eliminated. And it is truly a bone graft substitute it can be used in the absence of the need to harvest bone graft from the patient's iliac crest. So with regard to efficacy, and this is another enormous differentiator relative to the majority of materials you may be familiar with, we are conducting an IDE clinical study in conjunction with the FDA. So this will be the second material in the United States with an IDE Level 1 prospective human clinical studies. And there are, in fact, superiority data as compared to some of the other materials available in the literature, and we assume coming out of this study as well. So the data, in addition to the IDE clinical study being done in the U.S., we have a number of studies ongoing outside of the U.S., and we anticipate FDA approval for this material for anterior cervical spinal fusion in 2014. So I don't want to spend too much time on this, but I think it's important to understand how different this technology is as well as its mechanism of action. So the collagen molecule is one of the most ubiquitous and interesting molecules in the human body. And it was discovered that there is a specific chain of 15 amino acids along the collagen molecule that is the one and only segment of that molecule responsible for cellular attachment. So osteogenic cells, as well as cells regenerative for other tissue types, attach to this specific peptide link along the collagen chain, and that's what leads to their activity. If you take this peptide chain and pull it out, or synthetically manufacture it as we do, you can then put it onto a matrix, and it will dramatically facilitate the attachment and then the subsequent activity of cells, such as bone-forming cells. Now, I think it's important to point out the fact that a peptide, as being a small segment of a protein molecule, has a very specific activity, and you don't have a lot of other additional biological activities that can happen with a full protein, such as just the BMP as an example. So our product is one of, we're aware of at least one other peptide-enhanced bone substitute material that is currently in clinical trials in the United States. So we take this small segment of the collagen molecule responsible for cellular attachment, we attach that onto the surface of an anorganic bone material, and then we mix that with a carrier to facilitate intraoperative delivery, and that yields the product. So this is just sort of a schematic talking about the mechanism of action. So here in this cartoon, you can see sort of the yellow material is that ABM, anorganic bone material. The peptide is on the surface, and this really facilitates attachment of osteogenic cells onto that material. Once those cells are attached, they then begin to go down the pathway of preparing bone material. They release cytokines, growth factors, etc., and it really turns that bone formation process on. And this leads to, in the clinical applications we're studying, spinal fusion. So I'm now going to hand off to Dr. Jansen, who's going to talk about our U.S. clinical study, the construct of the study, and then the data we anticipate having very, very soon.
Thank you. I'm Mike Jansen. It gives me a great honor to have the opportunity to share some information with you. I'm a spine surgeon in Denver, Colorado. I've been practicing there for about 25 years and been involved in a variety of different clinical research, primarily in spine and orthopedic spine technology. We started a clinical assessment of this technology utilizing peptides in the cervical spine with a clinical IDE, an FDA-approved or FDA investigational randomized prospective clinical trial in 2006. And so I'm going to share with you is just a summary of where we've been over the last 7 years and a little bit about the study itself. So this is a study that was a randomized prospective clinical trial in cervical fusions in patients with cervical degenerative disc disease for one level. The patients were enrolled from up to age 70, and we started this in 2006, and we just completed the enrollment of all of the sites and the patients this past May. We would anticipate evaluating all of the data this fall to winter and for approval in the first part of 2014. Now, when does a patient get an anterior cervical fusion? It's one of the most common operations as a surgeon that I do, and one of the most common procedures that I see patients for. Patients come with arm pain, usually more than neck pain because the cervical disc itself compresses a nerve and or the spinal cord. And this is taking a look graphically at a transection or an axial picture of the cervical spine. And what you can see is the disc itself. Is there a pointer here? Okay. There's the disc, and then you can see the spinal cord and each of the nerve roots. The disc itself, there are 7 vertebrae in the cervical spine. Each then subsequently has a disc between C3 and C7. And the disc itself can degenerate and herniate, compressing the nerve. When that occurs and a patient fails to improve, evacuating that disc and stabilizing it really is the standard of care. So the goal of this study was to evaluate a P15, or specifically a peptide attachment factor, as an investigational device compared to the routine surgical procedure for an anterior cervical fusion utilizing local bone inside an allograft. And we did a randomized prospective clinical trial over multiple sites. We had 23 investigational sites between the United States as well as Canada, and initially with 250 patients. The patients were randomized and didn't know whether they were going to get the peptide attachment factor or just a standard allograft and local bone as part of the clinical trial. What is the measures of outcome? Well, we've changed, and I've been involved in a number of clinical trials for spine surgery, and what used to be the measure of outcome is only fusion. Really, the measure of outcome in all of our technologies today is function as well as fusion. And so we followed not only fusion as a primary measure of outcome, but functional data, something we never had in the historic literature before. And that's why it's so important, I think, to be able to track, measure, and monitor technology such as this so that we can follow the function in our patients. So we followed fusion as a measure of outcome, the Neck Disability Index, which is a measure of function and was utilized in other technologies such as total discs and other technologies we've been using. Neurological success, that means the ability to decompress the nerve, to improve the patient's overall function, and then, of course, follow complications and adverse events. Those are the 4 primary measure of outcomes we were required to measure success for the FDA study. We also followed pain, SF36, another measure of function, as well as postoperative kyphosis. Now let's talk a little bit about how this works. So what we do from a surgical standpoint is approach the neck from the front because the pathology is in the front. So we make an incision in the front of the neck and access the affected disc between C3, 4, 4, 5, 5, 6, or C6, C7. We then utilize most of the time with a microscope, evacuate the disc and remove it. The disc is about the diameter of a dime in size. Decompress the spinal cord and the nerve roots, and then prepare the bone so that we can actually get a stabilization for the long term, which is what a fusion is. Now, the best way then, once we remove that, we then pick the right size of the structural graft to put in, and in this case, allograft. Now, once you take an allograft structure like this, we have really a couple of options. We can either take this structure and fill this in with local bone, which is the bone that we remove when we're using a burr to prepare the implate, or we can insert this. Half the patients then had the peptide attachment factor inserted in, and then the graft was meticulously placed between the 2 vertebrae, just like this, and then it would stabilize with the plate. The plate provides immediate stability, and then the biological incorporation of the graft provides the long-term stability for the patient and the segment. That's the goal of the fusion, the instrumentation, and the stabilization. In my career in the last 20 years, we've changed a lot of our techniques because by utilizing a plate over a structural graft like that allows us to rehabilitate and mobilize and get the patient back to their activities at a much rapid than comparing to immobilizing them for long periods of time. This is what a long-term result, or actually probably 4 to 5 months, looks in our patients involved in these studies. Again, half the patients here would have had this allograft placed with just local bone, and half the patients had a peptide attachment factor placed inside the structural allograft to stabilize and to be able to create the best biological environment. So we have a great pool of data in a randomized prospective clinical trial of an incredible technology utilizing peptide attachment factors. And now going forward, as clinicians, we really need to be able to measure our success and measure this technology, but we really can't monitor it if we have no ability to measure it. So I think clearly this outlines we're going to have a vast pool of technology and data on a new peptide attachment, but we really need to be able to monitor as well as measure this on an ongoing basis regarding what we have learned over the last 7 years from running these clinical trials.
So I think we'll just wrap up here with the rationale why we believe a separate code is necessary for this new category of peptide-enhanced bone materials. So currently there are no ICD-9 or ICD-10 codes that specifically call out this category. There have been none approved by the FDA to date. We're going to have the second only full IDE level 1 clinical trial data available on this material. And if you look at the other autograft alternatives that are available that are currently used in these procedures, which include autograft, allograft, DBM, BMP, and synthetic bone graft materials, with the exception of infused BMP, there are no separate codes and there is no level 1 clinical data to support these materials. So for that reason, this is a material with a new and different mechanism of action. We believe the efficacy and safety profile will be different than those other materials, and it will be important to track the clinical outcomes as well as the cost structures for that going forward. So it is our request that CMS grant a new code for, not for our product, but rather for the category of peptide-enhanced bone graft materials. Again, P15 is the first one we anticipate approval of, but there is at least one other peptide in clinical trials to date. Thank you.
Thank you. Before we move on to the coding options, are there any clinical questions?
Hi, I may have missed this, but...
Can you state your name, please?
Oh, sorry. Hi, Maddie. It's Linda. I'm Linda Holtzman, Clarity Coding. You may have said this, Doctor, but perhaps I missed it, but is P15 used alone inside the allograft ring, or can it be mixed with autograft and other allograft or other, DBM? Is it always used by itself, or can it, and is it sometimes mixed in with the other materials?
Well, I can only comment on, in the United States, our clinical trial was very specific, as all clinical trials are, on how it's to be used. In this particular case, it's used by itself with a structural allograft. We're not mixing it with DBNs or with local bone. It is a separate peptide attachment factor that's used by itself in the structural allograft. What this is, I think it's the best way to describe it is this: what it's not what it is. It's not a bone void filler. It's not a demineralized bone matrix. It's not a BMP. It is a completely different osteobiologic, and that's why I think it makes it so unique. But it's primarily used by itself with a structural graft to enhance bone healing. And I think that's the exciting part as we see new technology, especially peptides.
Is this CE marked in Europe?
I don't work in Europe. I do a lot of international teaching. I think the answer is yes, but I don't want to give you the information. Maybe we can comment.
Yeah, absolutely. Yeah, this material does have a CE mark, and the indication for the CE mark is very broad. It's essentially all spine as well as orthopedic procedures. We have well over 10,000 procedures completed outside the United States in virtually any application you can imagine in orthopedics. In many of those procedures, it is used by itself as a standalone autograft replacement, but certainly by surgeon choice, it is frequently mixed with another bone graft, such as local bone, or sometimes some of those other technologies, but I think that's relatively rare.
Thank you.
Are there any other clinical questions in the audience right now? Okay. We're on page 14 of the handouts. Oh,
I have
okay.
a question, but this is more coding, so should I wait?
Okay. Yeah, if you could wait just a couple minutes. Okay, thank you. Okay, at the bottom of page 14 of your handouts, we have coding option 1, which states, do not create a new code. Pat discussed we're in the partial code freeze earlier, and considering that the requester did not submit an application for new technology. However, if the requester should decide to submit the application for new technology, then we can consider a new code request at that time. So for now, the interim advice would be to code the insertion of the bone graft substitute P15 to 3E0U3GC, which is introduction of other therapeutic substance into joints percutaneous approach. Sorry, I have to get used to these slides. Okay, on page 15 of the handouts, we have a consideration for October 1st, 2015 implementation, and that would be to use the existing qualifier value C, which is other substance, in the operation introduction and add an approach value 0 for open. And that is what it would look like. Option 2 would be if you submit the application for new technology, we could add the new qualifier value D for P15 peptide enhanced bone graft in operation introduction and add approach value 0 for open. We're on page 16 of the handouts now. So the CMS recommendation at this time would be for option 1 for the October 1st, 2015 implementation to use the existing qualifier value C, other substance, in introduction and add the approach value 0 for open. And again, the interim coding device as I just described earlier. Do we have any comments or questions?
Good morning. This is Barb Peterson. I do have a comment. And again, we understand the code freeze. So there's a couple of things going on with this device. We are looking to get approval in 2014. We are still looking at applying for a new technology add-on payment before the year's end. So with that said, we would certainly request a new code. More importantly, failing that, we do still believe this deserves a new code, primarily because of looking what other substances would be involved if we did CMS's long-term recommendation, which puts this in the other substance code, or other substance area. As Dr. Jansen clearly delineated, this protein or peptide-enhanced bone graft is substantially different than other products that would be put into this C qualifier of other substance. And our concern is, as we get on the market with this, we do know other payers are going to request separate coding so they can track and look at both the clinical and economic data on this product. So we certainly request that the consideration be to add another qualifier of peptide-enhanced bone void filler, or bone graft. Thank you.
Thank you, Barb. Was there another comment for the coding?
Darlene Hyman with Upper Chesapeake Health. So this procedure is done with the fusions, and so it's done with the inner body fusion. Is that correct?
This technology is to enhance the fusion. So yes, this technology is used to obtain a fusion over that segment. And in the cervical spine, 95% of the procedures are performed from the front, so they would be all interbody fusions. That is correct.
Okay. My concern is from a coding point of view, it's not clear, I think, from all the examples that are out there when we're on coding fusions, is that the coder would, in addition to coding this fusion, would add another code for this substance. And that I'm only speaking just because of all the examples out there in the training materials, and I just think it would be helpful. It would be really nice if PCS actually had like an add-on code, like CPT, or make sure you code this also, but maybe something could be added in the guidelines.
Okay,
because I'm afraid that it might get missed.
All right, you could submit those comments formally. Thank you, Darlene. We have another comment, question?
Just wanted to add on to what Darlene said, which is that right now we have an add-on type code, I don't know whatever terminology to use for that, for BMP, and we do an ICD-9 too. So this would be another add-on for P15, but I find it's confusing on what to do with other types of bone graft substitutes, like DBM and There's osteoconductive and osteoinductive and osteopromotive, which I think is a word the AMA made up. And there's just so many other types of bone graft substitutes that are used in the spine and also in other types of bone defect. So we'd need some guidance as well on when to use an add-on code for putting material in a bone defect and what types of bone graft substitutes are not coded separately. I will follow up in writing.
Yes, thank you, Linda. Great comments. Are there any other clinical comments or questions for the coding?
Can I make a comment?
Yep.
I agree with your comment upon where would you place all these others. But we have to also think from a clinician standpoint. We don't have data on most of the other technologies that we list under other. The demineralized bone matrix, we don't have great randomized prospective clinical trials. And these other items that are in the other. And if we spend 7 years collecting really good data, the most important thing is to be able to continue to go forward and look at the cost effectiveness and to look at outcomes. And the only way to do that is to be able to monitor, and the only way we can monitor is to measure. And so that's why I think whenever we finish a clinical trial on something totally novel, such as a peptide, the ability to categorize it separately so we can monitor both globally as well as in the US, the outcome of this technology is essential. And to lump it into other going forward, I think, is going backwards and not really helping us advance the most cost-effective way to look at technologies like this.
Okay, thank you everybody for your comments, and we'll look forward to receiving the application for new tech, and you'll probably see another code proposal at the March meeting. At this time, I'll turn it back over to Pat.
Thank you. It was a pleasure. Thank you.
We'll now have Amy Gruber come up and introduce her speakers for the implantation of the phrenic neurostimulator, and that begins on page 17 of your handouts.
Thank you, Pat. The issue is, should new ICD-10-PCS codes be created to identify the implantation of a neurostimulator with placement of a stimulating electrode into the right brachiocephalic or left pericardiophrenac vein and placement of a sensing electrode into the zygous vein, and also the associated removal procedures used in the treatment of central sleep apnea. CMS has not received a new technology application for fiscal year 2015. Here to provide us with a clinical background of this procedure is Dr. Ralph Augustini. He is the assistant professor at Ohio State University. Dr. Augustini.
Okay, great. Thank you. Thank you. I've been involved with the development of the phrenic nerve stimulator over the past 7 years, and we're currently involved in a clinical IDE trial for its future use. Respicardia has developed a neurostimulator device called the remedē system to treat central sleep apnea. The purpose of this presentation is to request the new ICD-10 codes for the lead placement. My agenda will be an overview of central sleep apnea, or CSA. We will talk about how the remedē system works as therapy for central sleep apnea. I'll describe the remedē system, the implant and explant procedure of the system, and the rationale for new ICD-10 codes. Central sleep apnea is a pattern of breathing where a patient experiences hyperventilation followed by apnea, which is a pause in breathing, or hypopnea, which is a characteristic form of breathing pattern. This is typically caused by the brain to fail to respond appropriately to changes in carbon dioxide. It's a devastating disease because it increases hypoxia, ventricular arrhythmia, atrial fibrillation, spontaneous sleep arousal, sympathetic activation, and results in increased stress on the heart, as well as adverse myocardial remodeling and impaired cardiac function. As an electrophysiologist, I primarily see this in patients who have either atrial fibrillation or heart failure. Our diagram shows the pattern of breathing, with normal breathing being cyclical and central sleep apnea breathing being a pattern of shallow breaths, increased rate, deeper breaths, followed by shallow breaths, and then a pause in breathing or apnea. During sleep, respiration is regulated by the brain's Respiratory Control Center, or RCC. The goal is to maintain a constant carbon dioxide level. To keep the carbon dioxide regulated, the Respiratory Control Center sends signals to the diaphragm via the phrenic nerves, which thus control the pattern of breathing. In patients with increased sympathetic drive and overactive chemoreceptors, the Respiratory Control Center sends inappropriate signals or loss of signal to the diaphragm, causing the irregular pattern of breathing. So again, we see the irregular pattern of breathing. This is a threshold for carbon dioxide in the Respiratory Control Center, and we'd like to see it at this target white line with an apnea threshold dropping below the yellow line. And as a result, if you have a respirometer on the patient, you can see a rapid pattern of breathing followed by pause and apnea caused by inappropriate levels of carbon dioxide. Intervening in this pathway by managing the stimulation of the phrenic nerve via the remedē system causes the diaphragm to contract and regulate the breathing pattern, thus stabilizing carbon dioxide. The remedē system includes a neurostimulator, seen in the right chest of the patient, the stimulation lead, which is the red lead, a sensing lead, which is the green lead, a programmer, and a wand to communicate with the device. This device is implanted by cardiac electrophysiologists, and it provides transvenous unilateral stimulation of the phrenic nerve to treat sleep apnea using a sophisticated algorithm for breathing. There are two locations where we can place the transvenous lead. The left paraphrenic vein is the small vein that comes off the innominate vein. The innominate vein is the large vein here. We're talking about this small blue line that comes down along the border of the heart to the diaphragm. The phrenic nerve on the left parallels this vein. The nerve is in yellow. On the right side, the right brachiocephalic vein is just above the superior vena cava and forms at the junction of the subclavian vein and the jugular vein. This is the second site where there's venous proximity to the phrenic nerve, which is here in yellow. Placement of either a left or right-sided vein depends upon the patient's anatomy. And whether we place the lead on the left or the right, the clinical outcomes have been similar. This is an image, an X-ray image of the left paraphrenic vein. The device is placed from the right shoulder, but there's a catheter that's used to visualize the vein, and we can see the tip of the catheter here with a contrast injection that outlines the target vein. Our procedure involves gaining venous access with specialized tools, locating that target vessel, and then subsequently placing the lead in a position just above the heart. Once we have the lead into position, we test the lead for nerve capture. The way that the lead captures the nerve is in proximity. It's not in direct contact with the nerve itself. The right stimulation lead is placed in the right brachiocephalic vein, which is, again, anatomically adjacent to the right phrenic nerve. So in this area between where the superior vena cava, the left brachiocephalic or innominate vein come in, we're looking at a target area here where the vein is in close proximity to the nerve. Again, we access the target vessel through a subclavian puncture in the right shoulder, deploy the stimulation lead with electrodes that are in close proximity along the lateral margin of the right brachiocephalic vein. We test for nerve capture. The sensing lead is placed in the azygos vein, which is a vein that comes up the posterior thorax through the mediastinum and into the superior vena cava. This image shows the superior vena cava with a catheter that's engaged in the azygos vein. The azygos vein has a upward movement and then also posteriorly toward the spine and then down the posterior thorax. The advantage of the azygos vein is it brings the sensing lead in close proximity to the diaphragm, so it can read diaphragmatic signal. Once we deploy the sensing lead, we perform stabilization and electrical testing of all the leads. The stimulator itself is placed similarly to a pacemaker or an ICD in a right prepectoral or submuscular location. The leads are secured at the entry site into the vascular space. We connect the device to the leads, put the device in the pocket. If the patient has a concomitant device like a pacemaker or a defibrillator, we test to make sure that there's no interaction between the devices, and then we close the pocket. Once the pocket is closed, we do a final electrical test to make sure things are working properly. The removal of a remedē system should be performed only by qualified personnel for indications consistent with HRS guidelines or Heart Rhythm Society guidelines for lead removal. The equipment used to remove the stimulator and the leads, both sensing and stimulation leads, would be similar to what's already used currently for removal of pacing or defibrillator leads. This would include locking stylets, removal sheaths, and fluoroscopy equipment. Central sleep apnea is associated predominantly with structural heart disease and symptomatic heart failure. The risk factors for Medicare beneficiaries are predominantly male gender, elderly patients, patients with atrial fibrillation or ventricular arrhythmias, and heart failure hospitalizations. The rationale for obtaining a new ICD-10 code is that there is currently no ICD-10 code that describes transvenous placement of a stimulating lead into the right brachiocephalic or left paraphrenic vein, nor is there a code for a sensing lead placement into the azygos vein. We believe these are clearly different targets than what exists for open surgical procedures for placement of neurologic stimulators. We request CMS to develop ICD-10-PCS codes that describe the implantation and removal of both the stimulating and sensing leads. Thank you.
Are there any clinical questions for Dr. Augustini? If not, we will move on to the coding options. Thank you. Coding options begin on page 18 of your handout. There are two coding options there before you. Option 1 has two parts, identifying the insertion as well as the removal of the device. Option 1A would be to continue to assign one of the following ICD-10 PCS codes for the implantation of the neurostimulator generator. And as you can see on the slides, we currently have two options available depending on the approaches. Second part of option 1 would be to continue to decide one of the following ICD-10 PCS codes for the placement of the stimulation lead into the right brachiocephalic or left pericardiophrenac vein and a sensing lead in the azygous vein to stimulate the phrenic nerve. So what you see on the slide is our various codes identifying that there's insertion of the lead into the peripheral nerve, identifying once again that it is the nerve that is being stimulated by the lead that is adjacent or near the nerve. Coding option B to discuss how we would code the removal of the procedure. We would suggest that you continue to assign one of the following ICD-10 PCS codes for the removal of the neurostimulator generator. Similar to the insertion, here are the two codes for the removal. And then we would continue to assign one of the following ICD-10 PCS codes for the removal of the associated leads that lead to stimulating the peripheral nerve. And as you can see, these are the current removal codes. Okay, so then option 2, as the requester has recommended, option 2A would be to continue to assign one of the ICD-10 PCS codes identified previously for the implantation of the neurostimulator generator. CMS would add device value M, neurostimulator lead, under the root operation of insertion of upper veins, zygous vein. CMS would also create under the root operation for the insertion of upper veins two new body parts, W to identify the pericardiophrenac vein and X to identify the brachiocephalic vein. In addition, device value M, neurostimulator lead, would also be added for these veins as illustrated below. And then for the removal, we would continue to assign one of the ICD-10 PCS codes for the current ones for the neurostimulator generator, and then CMS would add 3 body part characters, 0, azygous vein, 1, pericardiophrenac vein, and 3, brachiocephalic vein under the root operations of removal of upper veins. CMS would also create a new device, value M, neurostimulator lead, as illustrated in this slide. CMS's recommendation at this time is option 1, reporting of the neurostimulator procedure codes in addition to the diagnosis code for central sleep apnea would identify this procedure. Are there any comments, questions?
Hi, I'm Barb Peterson. We respectfully request that CMS consider option 2A and 2B. First and foremost, both the sensing and stimulating leads in this procedure go into the vascular system, not into the nervous system. And I think that would be very confusing for coders as they're looking at operative notes, because we're not talking about placing the leads within a nerve or around a nerve. We're actually talking about placing leads transvenously into the different veins that were discussed. Also, this procedure certainly could have FDA approval in 2015, and with that, the opportunity to do a new tech add-on would certainly happen. So thank you.
Thank you. Yes?
Linda Holtzman with Clarity Coding. In the interest of full disclosure, I'd like to note that I sometimes do consulting for Medtronic, which manufactures neurostimulators. However, as far as I'm aware, they don't have a product like this, so I don't have a horse in this race.
Okay.
But although Barb and I had an informal conversation about this, that's the extent of my involvement, my personal involvement in this. I have to say that I'm inclined to go with option 2, which is to create the new body part values and device values in the table for the vascular system. There seems to be sort of an assumption in ICD-10-PCS that the body system where a device is placed is the body system that is going to be affected by this device. And generally speaking, that's true. But there are already examples of devices which are placed in one body system but affect a different body system. And from what I can see, those are coded in the body system where they're placed. So the simplest example of that, or the most obvious example of that, would be placing a generator for a pacemaker or a neurostimulator or a defibrillator, whatever, in the subcutaneous tissue. Well, those are cardiac or nervous devices, but they're in the sub-Q tissue and they go to the sub-Q body system. That makes sense to me. There's a couple other examples too. For example, and this is a neurostimulator example, when you put leads in the stomach, that's in the gastrointestinal system. It's not in the nervous system. So it's, and you know, another example, now that I think about it, is with the carotid sinus stimulation, and those stimulator leads also go in vascular. So it seems to me that there's already a precedent in ICD-10-PCS to put the device in the body system for where it is physically located, as opposed to what system it's affecting.
Okay.
So I would like to see that precedent continue. Also, just to be aware that there are other devices coming down the pike that have this same issue, where the device is being put in one body system, but if it's affecting a different body system. And the one that comes to mind, there was just a new CPT code created for this. It's peripheral field stimulation of the back. And it's a neurostimulator, but these leads go in the sub-Q tissue. They don't go into or at nervous tissue. They're just placed in the sub-Q tissue of the back, and they just sort of generate this stimulation and hope that whatever nerves happen to be around, you know, will pick that up. So there's no way to code that either. There's already a CPT code for that, but there's no way to code it in ICD-10. So I guess my point is that whatever decision you make for this, just to bear in mind the precedent that already exists in ICD-10, and to keep in mind that that's going to affect other types of devices that are coming down the pike that have this same issue of the device going into one body system even though it's affecting another. My last comment is you've made a recommendation for insertion and removal, but it seems to me that it would also need to affect revision, because I assume that, like any neurostimulator lead, these can get out of place and might have to be repositioned. So you need to look at the revision table as well.
Okay.
And now I'm
Great
done.
points. Can you please put that in writing to us, Linda?
Thank you. I'd be happy to.
Thank you. Anyone else? Thank you.
Thank you, Amy. We'll now ask Maddie Hugh to come up again, and she'll be going over some ICD-10-PCS addenda issues.
Pat, I just had a point of order. Could you confirm if the phone line is open for comments from the public? Because I got a message saying it might be on mute, and I just wasn't sure.
The phone lines are not open for comment, and I'll clarify once again, the only people who can comment are those that are in the audience today. Those that are participating by the conference line and by live stream cannot give comments during the meeting. They can, however, send in written comments to us later. We did not pay for an operator and moderator for the conference calls.
Okay, on page 22 of your handouts, there is just a quick note about the fiscal year 2014 addenda files being posted on our website as of June of this year. There is no slide that matches this, so if you're looking for the slide, it's not there. Also wanted to bring your attention to, again in the handout, that in the download section, there is a link entitled 2014 Addendum. And on the handout, there's a list of all the files that are available. So if you haven't yet had the opportunity to go out there and look, I would encourage you to look at these files and get familiar with the file names and the content. And lastly, on the handout is just some examples of what the files contain and the various names of the files. Okay, now we'll move to the slide set. We received a request to add information to the device key, and it would be for intraluminal stent systems for fiscal year 2015, and this request was to help in identifying appropriate coding for these types of devices. So the proposal would be for the intraluminal device term to add what you see listed for the various stent systems. I'm not going to read all of them to you. On the bottom of the slide, you'll see for the intraluminal device drug-eluting and heart and vessels, that would include a revision for that type of device because there's a whole family of them. Do I have any comments?
Hi, this is Barbara Calvert with Abbott. We actually made that request. Those are our products. We did review the 2012 device key and saw that several things are missing, so we're simply asking that they be added. With regard to the last one, as you said, Maddie, Zion's V is a very specific stent, so we thought it would be clearer for coders if we left out the V, and all of those stents in that family would be coded similarly.
Okay, thanks, Barb. And there will also be a little bit further discussion when we get to the device key updates later today. Any other comments? No? Okay. I'll turn it back over to Pat.
Thank you, Maddie. We're now going to move to page 23 of your handouts, and we're going to provide an ICD-10 general equivalent mappings updates, and Rhonda Butler is going to assist me with this process. We did post the fiscal year 2014 procedure and diagnosis GEMS in August 2013. So those of you who wanted a more up-to-date GEMS, you now have those matching the code updates. We encourage you to look at those, the new issues, things that are previously there, and if you have comments that you think you could make the procedure, that the GEMS work better, we continue to encourage people to send us specific comments about the GEMS, and it's a continuous process of each year working on them. We would take any comments we receive from you now, looking at fiscal year 2014, and we would consider them as part of the fiscal year 2015 update. And we posted those along with the user guide, which I get calls from people asking how the GEMS work. Well, we have a user guide that we post with these files every year. I would encourage you to read that. And the documentation for technical users is also a very good resource for you. We also have a GEMS update summary that's included there. The diagnosis GEMS are also posted on CDC's website, so you can look for the diagnosis GEMS both places. And just to summarize, that the updates were because of new codes and because you've looked at the GEMS and made comments that you thought we could improve them. And as we look at things, we do internal review, and each year we try to update the GEMS appropriately. And I'll now turn over the floor to Rhonda, who will describe the types of comments we've received and some examples. We'll not go through all of the kinds of updates we had for the gyms this year. Rhonda Butler from 3M.
Thank you, Pat. As Pat said, most of the changes from the past year were received from public comments, and so that's what you have listed in your agenda is an extensive list of the public comments we received and the changes we made as a result of those. Those are included in this meeting's agenda, and those are also what's published on the CMS website in a PDF file called the CMS Updates Summary. So the types of comments that we receive every year are of these three basic types. We get additional translation alternatives that get suggested based on the inclusion criteria for the mappings. And those kinds of things, the inclusion criteria, are listed in detail in the documentation for technical users. We often get additional cluster translation suggestions for completeness. As you know, in both ICD-9 and ICD-10, we have what are called combination codes, where in one of the systems, a single code will give, for example, the underlying cause plus an acute exacerbation, and that takes 2 codes in ICD-9. So that full translation we call a cluster in the other code set. So those are the kinds of things that get requested for a more complete mapping reference. And then we get recommendations for revising entries that don't meet the inclusion criteria. And again, like I said, these are just the 3 examples that are on these slides are just examples of the types. There's a more full list of the kinds of comments that we received and changes that we made in the past year. So screening for gout. This is an example where the ICD-9 code has a specific V code. The ICD-10 code, the translation alternative, was changed to Z1389 because the index, although the code does not explicitly say gout, the index, the ICD-10-CM index, refers you to gout, Z1389. This is an example of making a cluster translation that makes the GEMS more complete from ICD-10 back to ICD-9. In ICD-10, you have a combination code that gives you the glaucoma codes with their corresponding stage. And so in ICD-9, you need the glaucoma code and the stage code, and a few of those were incomplete. There are a lot of glaucoma codes and a lot of clusters, and we just made those more complete. And then the last example here is an example in the ICD-9 to 10 GEMS where it did not meet inclusion criteria in the sense that the ICD-10 translation was trying to be more specific than the source code, the ICD-9 code. So the public comment we received was to make those levels of detail more equivalent from code to code. That's the whole point of the general equivalence mappings. And I'll turn it back over to Pat.
Just to save time, and I know this is technical, you can go through your handouts and go through each of these examples to get a flavor for the type of GEM updates, and then you may want to go through the whole document. But if anyone has any specific questions or comments, we would like to take those now.
Hi, Nellie Leon, St. American Hospital Association. Thanks for making these GEM updates public so we can actually follow through. And I'm wondering if there's one that you may be able to kind of walk me through or kind of explain what the rationale is, because I was able to figure out all of them except for one.
Okay, we'll have Rhonda to come back up and we'll go through that one right now.
Okay.
Could you tell everybody what page in the handout you're referring to?
Yeah, I'm on page 23, and it's the second one where it's the ADHD predominantly inattentive type. And it looks like the current GEMS walk you back to an ICD-9-CM code that says with hyperactivity, and hyperactivity is part of the ICD-10-CM title, but it's being updated to without mention of hyperactivity. And maybe this is a clinical question, and because I see your rationale, but it sounded like the default code didn't specify whether there was any kind of hyperactivity or not. So I was trying to kind of figure out if I was missing something in this particular example.
No, I'll have to go back to the book and check to be sure, but it's possible that I might want to refer this to the CDC because it's possible that the full title of ADHD always has the word hyperactivity in it, but it doesn't include, but ICD-10-CM further qualifies whether hyperactivity is a subcategory of the disorder that's being diagnosed. In other words, you have a hyperactive type of ADHD, but the H is always part of the diagnosis code, if that makes any sense.
Okay, because I was trying to figure out if the rationale is following the index or the meaning of the code, and I thought you were always going after the meaning, and I have to admit I didn't understand what the difference is, but okay, so you're really going after the meaning of the code.
As insofar as possible, we're trying to get a patient who would have the diagnosis from a doctor, how a coder would code it in ICD-9 versus how a coder would code it in ICD-10. And the treatment of the word hyperactivity might be different there in the code title, because notice in ICD-10, attention deficit hyperactivity disorder is part of the entire, all the codes in that subcategory, whereas in ICD-9 it just says attention deficit disorder. So it may be that they just renamed the acronym ADD to ADHD, but it doesn't necessarily mean with hyperactivity, just because hyperactivity is in the title. So we'd have to look at the includes and excludes in the index, which I can't do up here.
No, I know, and I didn't bring that with me.
I'm actually crossing the line beyond what I know right here, standing here.
Okay, I was just primarily interested in sort of the logic behind it. I can go back and review that and include that in our comment letters in terms of reviewing the index and so on. Okay, all right, thank you.
And Nellie, raising that reason is a good point. The reason we put in the logic change, we've gotten comments on all of these. People want us to change. Maybe when we evaluated the suggestions, maybe they're not right. And if you want to look at them and you think that we want to modify the ones we've updated this year or others, then we would really encourage you to bring those to our attention, and we will consider additional refinements if after you study this or other issues you'd feel like it could be improved. We have another comment?
Actually, it's a comment and a question on page 29. My comment is I wanted to thank CMS for clarifying this particular principle in the GEM for a heart assist device. That this, to me, really clarifies how these things are supposed to be coded. So I appreciate that you now have a guiding principle for what to do when the pumping mechanism is implanted and what to do when the pumping mechanism is extracorporeal. Thanks. My comment then is I appreciate the changes for the GEM for 3762, 3768, and 3766, but I'm not sure why 3760 and 3765 also weren't updated, because right now the GEM for those two codes, that's for insertion of a biventricular external heart assist device. The GEM for those two codes is just for 02H and as it's implanted. But I think there should also be a 5A0 with that as well, because for those devices, the pump is outside the body. So following this principle, it would seem like you would need both codes.
Thank you, Linda. And it would be extremely helpful if you put that in writing. I believe, and Rhonda, correct me, that this is an issue we've been analyzing internally, so it would be helpful to have you and others to look at this section and make suggestions for the fiscal year 2015 update.
And I should note that I'm also now strolling outside the area where I know what I'm talking about, too.
Right, off the cuff from up here is very dangerous, but I just wanted to thank Dr. Dan Duval. We have him to thank for this principle, but we may not have implied it perfectly the first time around. So if you see inconsistencies, send your comments in writing, please.
Thanks. And pass along my thanks to Dr. Duval, too. This principle is terrific. Thanks.
Great job, Dr. Duval. We appreciate all his help on our coding issues. And so I thank Linda and Ellie for both looking at these and raising other issues, and maybe that'll encourage the rest of you to dig into the GEMs, because we want to make it as good a living document as we can. We'll move now to the page 33 of the handouts, and we'll discuss the ICD reimbursement map improvements. For those of you who've been around for a while, you recall that we developed the reimbursement maps at the request for payers who were concerned that they couldn't map or convert their payment systems to ICD-10 in time for implementation. And they said if we had a tool where if people sent in an ICD-10 code, we could map it back to the closest ICD-9 code, and that might tie us over before we got our payment conversions done. And so that's what we did. And we acknowledge that we did that based on Medicare data. It may not be the same as if you used it for other payers, and it's a tool that people have used. I think many payers have gone beyond that. They've used the general equivalent mappings. They've converted their payment system. And I don't know that a lot of people use the reimbursement mappings for the intention that they were developed for. We've gotten other comments that said they've noticed that our reimbursement maps didn't map the thought process or logic used in the MSDRGs, and they wish they did. Now, one can never make a tool useful to everybody, but since we got that recommendation, we did improve or modify the fiscal year 2014 reimbursement map, which you're going to see later this year, so that it has enhanced logic, so that it now does take into consideration ICD-9 and ICD-10 as used within the MSDRGs. And if that's helpful to you, then we're glad of that. And for those of you who have wondered why we didn't use this thought process before, that's why we're proceeding this way. Most of you probably have not used the reimbursement map and may not in the future. And for those of you, I say fine. Donna and I always say, most people aren't going to use the GEMs and the reimbursement maps. You need to just pick up a code book and learn to code, and that's the fastest way. And to try to use all these other tools to get down to that fact, it's not going to help. So for that very small percentage of people who use the GEMs and reimbursement maps for their unique purposes, we just share what we've done this. The reimbursement maps will be posted within the next couple of months on our website. Now we'll go to the MSDRG update, page 33. And we have an announcement that I'm extremely pleased about. As you know, in February of this year, we posted version 30 of the MSDRG's links to order the mainframe and PCS software. We've been for years hearing from people they appreciated having a PC version. That was great, but a mainframe would be helpful because a lot of people were getting into serious analysis and they wanted the mainframe version, and we've released it. And we understand just from hearing from MTIS, people are taking advantage of it. The good thing about making this available is people have gotten into more detail looking at the ICD-10 MSDRGs. They understand our goal is to make the ICD-10 MSDRGs assign the same patient to the same DRG, whether you're using ICD-9 or ICD-10. Did we replicate the group with ICD-10? And having the mainframe available, people run a lot of cases. People are getting down into the weeds finally. And we're getting some good comments questioning if we've done a couple of MSDRG ICD-10 assignments correctly or not. We want you to keep that up during this final pre-year, analyze it, and if we've missed anything or you could think of an improvement, we want you to let us know. And in that vein, We are now planning in October, 1 year before the implementation of ICD-10, to post the version 31 ICD-10 definitions manual. And that'll include a summary of changes for the DRG logic that we just updated, beginning with our grouper that's going into effect in a couple weeks, version 31 of the ICD-9 DRGs. We'll also post the definitions of the Medicare code edits, and I give you on this slide and in page 33 of your handouts information where all these definition manual documents will be located. And more importantly, and this is the big deal, we plan by late October to make available the version 31 mainframe software for both NPC, for the grouper, and for the MCE through NTIS. So you've got one more shot of the most recent logic to examine, have we done a good job of replicating the ICD-9 MSDRGs that we use now and making an ICD-10 version. We love your comments. Please don't call me on the phone. It's hard to follow what you're saying. Send me those comments in writing and be as specific as possible. Things such as, I don't think you got this right, are not helpful. Things such as, this code under this DRG should be moved to whatever, and here's the reason why, is extremely helpful. And so keep up that, and when that is posted, the information will be on our website. And for those who are on Maddie's listserv announcements for this meeting, we'll send out a note the day we post it saying that these things are available. Now, even though we were doing all this work, and we've been doing this for a number of years, keep in mind that all these things we're posting are just advanced to work with you to get your input. They are not final. What we CMS staff will be doing beginning, we actually start our MSDRG work in November and early December. We will start working on version 32 of the MSDRG through formal rulemaking that will go out in April of next year, where we will tell the public what version 32 of the MSDRGs would look like. That's the first time you'll be able to comment formally through formal rulemaking. And if we have an additional suggestions for refining the MSDRGs like we do every year, we'll discuss those also. But next year's proposed rule will be a big deal because it will be the time we propose actual implementation of an ICD-10 MSDRG system and tell you where all the codes will be. And we'll welcome your comments early this year so that we can do a really good job when we post in April of capturing the DRGs and ICD-10 so that we don't create any confusion. We want to deal with them now, and then we will formally propose them for fiscal year 2015. I'll now turn the podium over to Maddie and Rhonda, who are going to go through some updates being made in the ICD-10 keys.
Okay, we're on page 34 of your agenda and handout packet, and the slide just shows the fiscal year 2014 body part key updates, and this ties into page 22 of the addenda. I talked about those files that are available, the definitions file. So if you look at those files, you would see the revisions, the changes and updates, and then this is what it looks like.
Several years ago, when we first introduced these additional references in ICD-10-PCS, the first one we did was the body part key, as Maddie mentioned, and these were public requests to have some way in the official PCS content to cross-reference between clinical words that are used on a chart, body part anatomic terms, and the PCS values for the body part. So then a couple years later, we had the same request for the device key, and the principles that we use, again, terms, whether they're brand names or generic terms, but things that you would find in a coded record, but are not necessarily part of the PCS code description. They're not part of the device value, a way to cross-reference between those two. And the way we first developed it was we took device names that were used in the ICD-9-CM index, both common and proprietary names, and only as a starting point to ensure that old devices weren't being added to the PCS device key, and we had extra entries that we didn't need. We just started by using FDA-approved devices for the last 5 years. That is not a constraint. So we get that. That's a common misconception that we only keep devices that have been introduced in the last 5 years in the device key. That was just part of the initial populating of the device key, if you will. So from now on, as you've seen, CMS is accepting requests for any common or brand name entries to the device key. And that leads me to specific device key proposals for this year. Maddie showed a reference slide earlier in this morning's agenda that showed these requests for new entries to the device key, and they're listed by the device name, by brand name. I'll just let you read those yourself, and they're for stenting systems. And so in the PCS device key, you would have the brand name, and then you would have the PCS device value intraluminal device. And I think this would be the time, if there are any comments on these specific proposed device key entries, we could take those now.
Nellie Leon, St. American Hospital Association. First of all, thank you, CMS and Rhonda, because I think the device key was something that's very much needed. Having said that, I also have concerns that I don't want this to be so large and so cluttered that it becomes very difficult for coders to use. I think that once we know that a stent is an intraluminal device, the brand name itself probably doesn't make a lot of difference. And there's always going to be different brands and different styles of things that so long as they're still intraluminal devices, and they will be because it really reflects what you're doing with that device, I don't know that it makes a lot of sense for me personally to have all the brand names available. Because unless there's something specific to one particular brand that all of a sudden you're someplace else, that's an issue. Now, if something about the name of the device or the brand name would tell me that it's drug-eluting or not, that could be useful, but I don't even know enough about these devices to see if that's the kind of information people are looking for. The other danger is that the more brand names you put in when something is missing, it sort of creates the false perception that if it's not listed in the device key, what does it mean? Why are you excluding some? Does that mean that some of them are not approved or not recognized and so on? Which of course was never the intent of the device key, but just, some things to consider.
Thank you, Nellie. That was excellent. The slippery slope of offering a place to put information is that you get a lot of information.
Yeah. Hi, Barbara Calver with Abbott, and no, I understand Nellie's comment. I think we just have to go one way or the other. Either you have a device key that doesn't have anything, or that it has the possibility of including some, all things. So I think that's, a decision to be made. But it probably shouldn't be the case that it does include some things and excludes other things just because some things were put in the beginning.
Jim Nagel, Upper Chesapeake. I don't know what I think about this at the moment, because I think that certainly from attending this meeting a number of years, there's certainly been a huge parade of companies coming to seek codes for their proposed unique device. And I think just to decide that all stents are stents is maybe not what we want to do. I mean, it's getting more and more difficult for the coders with all the names and things that the surgeons and other people throw into the reports. And I don't know. I still got to think about this some more.
Linda Holtzman, I need to think about this some more too. I agree with Nellie, which is always a good idea, that the device key is brilliant. It's so helpful, but I also worry about it getting so big. At the same time, coders could be expending large amounts of time trying to figure out if the Smith device 1 and Smith device 2 use the same value, and oftentimes they don't. I mean, a lot of manufacturers have what they call a suite or something like that under a brand name, and then within that they have different products. They all use the same brand name, but they have some little change that's different in the name, the model name, and those models some would be non-drug eluting, some would be drug eluting. There's just no way for a coder to know that unless you're going to go on the manufacturer's website and sort through all that stuff, which is what we do now. So the device key, to me, is a wonderful shortcut for being able to figure out, is this single array or dual array, without having to spend 30 minutes on Abbott's website, so to speak. So, I share the concerns, but I also feel like the more devices that we put in here that are not intuitive, that would be genuinely useful to coders and would really be a time saver.
Thank you. Anyone else?
Or just okay, just leave it. Yeah. Those are extremely helpful comments, and now you see why we struggle with issues such as this when we get requests: too big, too many, too few. But it's great as you think about it, and as your decisions evolve, we'll seek those opinions while we improve the device key. One more comment from Linda.
Yeah, actually, I just wanted to mention, it's kind of funny with the device key because it's sort of like becoming a mark of distinction now. On some manufacturers' websites, they're sort of strutting, and we got our product onto the device key. It's like, we've hit the big time now. So another fact to take into consideration.
Good point. That was Linda Holtzman. This concludes the procedure part of the meeting, but I want to urge you once more, those that are not here in the room that are listening, and those in the room. Oh, I'm sorry. I missed the substance key. We'll go through that.
We got so into the device key, we have one more related proposal to put in front of you. This slide just shows the change that Maddie discussed before, where the Zion stent is a whole family of stents, so the V was removed. That's just a revised proposal. So we talked about the body part key, the device key. In the previous Coordination and Maintenance Committee meeting, we had requests to take the next step, which is to develop a reference area for substances. As you've seen in recent procedure requests, requests for new substances are increasingly coming to the podium at this meeting. So we were asked to develop a reference area for, again, a cross-reference between substance names used in the industry and PCS substance values that are in Section 3, the introduction section of ICD-10-PCS. And so the examples, the initial offering is published in your agenda. It's quite small for the reasons Nellie mentioned, and CMS made the decision that, remember, ICD-10-PCS is an inpatient procedure coding system, and so we're starting very conservatively with substances that have already been added to ICD-9-CM, so they're listed in the ICD-9-CM index, both the common names and proprietary names. So this new reference will be included in future updates of ICD-10-PCS, and the format, those of you who are familiar with the device key and the body part key, you can rest assured the format will be the same. The exact example format is included in the agenda. And again, listed by both common name and proprietary name if those are given. And then the definitions format shows the PCS value and goes the other way back to the common and proprietary name. So here's an example. K-Centra is currently in the ICD-9-CM index. And we tell you in ICD-10-PCS, the substance value is the full technical name, 4-factor prothrombin complex concentrate. That was a recent new code in ICD-9-CM. So there's the substance key format example. That's part of your agenda. And here are some other ones on this slide, the first several editions. And like I said, the full list that will be included in the initial offering is in the meeting agenda. And I'll turn it back over to Pat. This, like the device key and the body part key, there's an interest in public offerings or public suggestions for entries for the substance key.
Thank you, Rhonda and Maddie. And any suggestions we get for updates to the device or substance key, we can put on the agenda to discuss with your feelings about those for the March meeting. Nellie?
Very quickly, I think you need to consider the possible ramifications of making this available. It makes sense for the examples you have listed on the slides, but a few of the questions we've been getting at the AHA central office have been things where they've sent in an app report and they see injection or administration of XYZ, and then when they look up the substance on the internet, they see that it can be used for multiple purposes. So then the people are sending the questions to us and say, well, how do I code this? Is this an administration of, anti-inflammatory or, whatever? And my personal feeling is that if something like that has multiple uses, that they probably have to ask the doctor if it's not documented, well, why did you give this? So I guess something to think about as you develop a substance key within PCS, are there some substances that people may write to you about and say, add it, where they might have multiple uses, and so, what will you do then? Do you not list it? Or would there be an overarching guideline? But I think part of the concern is that, as we're reminded, this is an inpatient system, but because there is the ability to code all these things in PCS, I think people are getting kind of confused about it and, asking, well, do I need to code it now? What do I do now? I mean, something as recently that I looked at this week was someone did an imaging study, and now they're asking, well, they gave glucagon for a cholangiogram. Do I code that separately? So, I mean, this is kind of opening the door for lots of more questions.
Those are excellent comments, Nellie. We appreciate those, and we do need to proceed with caution. We want to make things useful, but we most certainly don't want to create confusion. Now I can really conclude the meeting, and I want to urge your comments on the two procedure code topics. And let me just be a little more clear about the kind of comments we want. There are a couple issues. First, there are proposed for code updates, and what we need to hear from you is whether or not the proposed updates for new codes was a good idea or not. You need to tell us, yes, it is for the following reason, or no, it's not. The second, even more important thing you need to tell us is if you agree that a code update's necessary, do you agree that it meets the new criteria and it should be October 1st, 2014? Or do you believe it does not meet that criteria, but you think that the code update is extremely valuable and you believe that we should look toward implementing the code update on October 1st, 2015? We need that depth of clarity from you in your comments. I'll now turn the meeting over to Donna, and we'll see if she wants to take a break or what. She says we take a break. Do you want to give them to 11? You have to 11 o'clock, And then just to let you know, for planning purposes, we will be having a lunch break at 12:30 to 1:30 as requested by the cafeteria. So those of you who don't know where the cafeteria is, you go down the hall, in the hall, and then downstairs and you'll find the cafeteria. Thank you very much. See you at 11 o'clock.